Bjorn and Inga have asked me to talk a little bit about the historical perspective of early intervention or ultra early intervention in the NICU. And it has been a very interesting journey for me to really get an idea of everything that is going on and has been going on for many years. It's like there are many threads of what was considered early intervention that we see with a historical perspective. And so I would like to think about this in terms of the threads that weave our understanding of early intervention in the NICU. We realize that early intervention spans a great amount of time, both in the NICU, as the babies are discharged from the NICU, in early learning programs, but I think we'd like to focus mostly on the evidence-based practices that have come through the years. Some of us have experienced a lot of those, and some of them were before any of us were involved in any kind of care of premature newborn babies. But I would like to think about threads of thought and practice over the years in terms of protection isolation, technology development, environmental modifications, supplementary stimulation, family-centered or integrative care, developmental neuroprotective care, kangaroo mother care, and I think we're at the point where we can really think about systems change, standards, and guidelines for practice, especially in the NICU. So I know that we're familiar with where neonatology started with babies who were born very fragile and very preterm. And it started primarily in France by Pierre-Constant Boudin a little bit before him, but he was the person who has this quote: the glass that he put in these incubators to keep babies warm permits the mother to watch every movement of the poor fragile little being. Thus, by watching him almost minute by minute, the mother becomes attached to her baby. When we think about all of the observations that we're now doing to understand the communication of the baby, this was quite insightful very early on in neonatal care. We also know that it was quite an interesting thing for people to do to look at babies in incubators at fairs. And in the United States, and forgive me, but most of my perspective comes from the United States, but I will try to include many of the influences that I'm aware of that have happened in Europe. But I was unaware that during the time of these World's Fairs, Gesell and Armatruda, who were very well known in the area of infant development, started to come into these World's Fair exhibits at night and started to do observations on the baby's behavior. And it resulted in the topic of the embryology of behavior back in the 1940s. Prior to the development of newborn intensive care units as we know it, there were premature nurseries. And during the 1950s, which was earlier than most of us were even born, the quote that came from Louis Gluck, who was the person who developed newborn intensive care units in the United States, had this interesting quote. During the 1950s, the mysterious fetus was untouchable, unseeable, unknowable, an invisible being with a heartbeat who was visible only with X-ray, with no way to determine accurately size or maturity. So what happened there with the premature nurseries was that there was a high rate of infection. And what happened was that they tried to have very few contacts with people who might have infectious processes going on. And so it was limited, the contact between the babies and the caregivers, to a very few number of nurses. And what happened was that the parents were then separated from their babies. And this is a photograph of how a public health nurse would go and collect the baby that was born in tenements and bring them into premature nurseries. Now, some pioneering physicians said, wait a minute, we've got to get these parents back with their babies. And so Dr. Edith Jackson began allowing parents into the premature nursery to see and handle their babies. And this began a new time of exploring the development of babies in under premature nurseries and intensive care. So I think I can get rid of that, can't I, Jordan? Okay. So in the 1960s, at least in our country, the first intensive care nurseries were developed, and infants were seen as very fragile, needing little handling and interaction. And those of you who are around really recognized that a lot of the head molding happened because the babies were positioned in a way and not disturbed very much, that there was a lot of plagiocephaly. Parents were typically not allowed in the NICU. And in my historical context, I can remember these very small NICUs, and no one, much less the pediatrician, could come in and disturb the babies because the nurses were so protective of them. So the next thread that we want to consider in terms of evidence-based practice in the NICU was supplementary stimulation as early intervention. So we had a shift then from seeing preterm infants as fragile beings to more that they were sensory deprived. And that's when the sensory stimulation studies began. And I'm not giving dates because all of these are woven through, but I'll try to give you who were the key players in developing these concepts and how they have continued or not continued or reemerged over time. One of the first publications was a randomized control trial of the effects of early stimulation on low birth weight infants by Scar Skalapatic and Margaret Williams. And Dr. Alls tells me that this is the time when she was a student and beginning her experience in NICUs. And what they did was they provided visual, tactile, auditory stimulation to the babies in the NICU, and then as they transitioned into the community, they were followed on a weekly basis for the first year after discharge. Now, of course, these are not the extremely low birth weight babies that we're seeing now. They were much more robust. So the nurseries were shifting from we don't want anybody to handle these babies or stimulate these babies too much to how do we provide extra stimulation so that they will grow and develop better. One of the first people who attempted to intervene from a physiologic standpoint and reduce the apneas was Annalise Corner in the early 1970s, and she developed a waterbed for preterm infants. And it's interesting that this is the copyright picture of how she developed the waterbed. Then shortly after that, Evelyn Thoman, who is a leader in theoretical development in the field, developed what was called the breathing bear. So this fuzzy blue bear was outfitted with a bladder, and the copyright is there, a bladder that would breathe at a rate, and the preterm infant, I don't know how to back up here, would then, we're going to have a broken foot, Bjorn. We can't have that. I can't share my cast. Oh, no, I need to go backwards just a little bit.
Page down.
Okay, nope, page up. Yep, sorry. There we go. So the preterm infant was shown to be able to approach the breathing bear, embrace the breathing bear, and match to some extent the breathing with the rate that the bear was breathing. So these extra simulation studies were done by Evelyn Thoman in terms of helping the baby to regulate his or her physiologic system. Early on also, Jean Anderson was providing non-nutritive sucking to the babies, and that technique, that extra stimulation has been proven through the years to be beneficial in terms of regulation. Then Ludington Ho thought, okay, let's provide more visual and auditory stimulation to babies, and published the book, How to Have a Smarter Baby. So most parents would want a smarter baby. So developed, and these are not her targets, but we see a lot of these targets, don't we? The rationale was to help the visual system develop. And unfortunately, what happened is that was adapted for the NICUs, and you would see these visual targets hung over very small, fragile babies. Now, none of these necessarily continued through the years, but there are some that have been adapted to new technological devices. There was also some multiple modality stimulation. Instead of one stimuli, they provided both auditory, visual, kinesthetic stimulation. Started by Dr. Rice in 1977, there were some studies by Barnard and Bee, as well as Rosemary White Trout. So that was multiple stimulation, and the thing that impresses me is that all of these kinds of extra stimulation interventions were done by a non-parent. And so it was done to the baby rather than with the baby and without the input of the parents. We go on to the really large body of literature on infant massage that was modified and provided in a more gentle human touch perspective by Linda Harrison and others in 1992. There are more recent technology-based sensory stimulation examples. Stanley has been a proponent of these pacifier-activated and other music therapies. Kathleen Philbin has an interesting rebuttal to the findings of Stanley. There are some new techniques for synthetic oral cutaneous stimulation, which essentially is this. It's a vibrating dummy pacifier soother, whatever terminology you use. And then also just published some studies by La Have, where the mother's voice was recorded and then played in the incubators. So the next thread that we want to consider in early intervention in the NICU is environmental modifications. And what they recognized at that particular time was that the effects of sensory stimuli bombardment on the baby was recognized to the extent that the baby was getting too much stimulation. And we were learning a lot more about the sensitivity to and learning about the effects of the environment on the developing brain, and Petra alluded to that in her talk this morning. We had more technology to be able to monitor the physiological responses to of the babies when they were exposed to these stimuli. And the wonderful, exciting new science about brain imaging was certainly coming on into play. So you can imagine that NICUs back in that day were overstimulating in themselves, regardless of adding more stimuli. And so there was an effort to understand through technology what the effects of the environment were on the babies. And this is the classic one by Long and Lucy in 1980 that showed reactions to the sound levels here, which are emphasized here, with physiologic responses of heart rate, respiratory responses, transcutaneous PO2, we didn't have saturation monitors back then, and intracranial pressure. And importantly, when the monitors were used to see how the babies physiologically reacted to these extra stimuli in the unit, then they were able to modify their own behavior. So it was a feedback mechanism for the people who worked in the NICU. Gottfried and Gator in 1984 wanted to really pay attention to the effects of the NICU environment on the developing newborn and published this landmark book, Infant Stress Under Intensive Care. What happened was then that there was an era of minimal stimulation. Those of you who are out there recognize that this was a real time when we tried to dim the lights, to lower the sound effects on the babies, to have, minimal stimulation protocols, clustered care to give the baby time to recover in between caregiving, and to minimize sleep disruptions. So we had nurseries who went to the extreme, where it was very dark, and those of you who lived during that era knew that it was a time of a lot of upheaval because nurses and doctors weren't able to see the babies well enough, they thought. And also, we wanted to minimize the impact of sound on babies during development. Unfortunately, there are still NICUs then, as there are now, who haven't really transitioned to understanding the impact of the environment on the developing babies. So about that time, there was much more attention to the effects of the environment on the preterm and developing baby. And so there were two publications that looked at the effects of the environment and also the role of caregiving in the social environment. Stanley Graven got a national grant award to bring together leaders in the field to think about how do we provide more supportive intervention by environmental modifications and caregiving in the early 1900s. And what we know now is they're now in their 28th, going into their 29th year of NICU design that takes into consideration the environments, the caregiving, and the parent integration. Then there came another thread of thinking about the babies in terms of their own development, the developmental approaches to early intervention in the NICU and beyond. We have the complement of developmental psychobiologists who look at basic science issues with either animal or human studies. The infant development started to guide the practices and the changes in caregiving. The NIDCAP studies provided evidence of positive outcomes, and there was more individualization of caregiving. There are many, many examples of developmental basic science to support early interventions in the NICU. I've named a few of the folks who I feel have really contributed to our understanding of some of the developmental issues that we need to pay attention to as we're devising early intervention programs. This particular photograph I have in here is work by Benoit Schall, who looks at the odor responsiveness of preterm infants to their own mother's odor. So there's an awful lot in the basic science that helps us to understand and adapt our caregiving and intervention practices in the NICU. I find it very interesting to see quotes from leaders in the field, and this one is by Dieter Volke, way back in the 1980s. And he said, in his review of all the sensory stimulation and wanting to go to a more developmental model, firstly, observe the baby before, during, and after procedures. How does he or she react? Secondly, design an individual plan of care to reduce stress and pain and be supportive of the infant's own behavior regulation. And thirdly, grow up with the patient. Now, that must sound familiar to many of us because they are basic tenets of what we do in the NICU today, especially with the NIDCAP approach. So then we started to see emerging the studies, and the initial one was a phase lag control study of the individualized developmental care using the NIDCAP approach. And we not only saw medical outcomes, but also developmental outcomes. And it had to do with changing the way we interacted with babies based on the baby's communication and what we can do to help support the baby's growth and development through the eyes of the baby and incorporating the parents into the caregiving as well. So there is mounting evidence, and many of the studies were done both in the United States and in Europe, and the evidence says that this particular approach that Petra alluded to this morning, the NIDCAP approach, works very effectively with extremely and very low birth weight infants, and we'll talk more about this later in the day, larger stable but low birth weight babies, and infants born intrauterine growth restricted. So out of some of the assessment of preterm infant behavior and Brazelton neonatal assessment scale, there came another approach, which was the mother-infant transaction program, originally published in 1993. And I mention it because it starts in the NICU with helping the parent to understand the communication of the baby and what strategies there would be to support the organization of the baby, and then continue to follow the baby for 7 more sessions in the home. And the follow-up studies are now to 9 years of age. And this is a testament to continuing to follow these babies long term, because at first they didn't see a whole lot of difference between the experimental and control babies, but as the babies continued to grow, they found profound differences in cognitive outcome. So as you all know, it's been presented at this meeting previously, there are an awful lot of now application of the MIT program in high-risk infants, a lot from the Netherlands, a lot from Australia, and we're glad to know that those kinds of interventions are ongoing. And there are also some post-discharge early intervention programs that you'll hear more about today with the Infant Behavior Assessment Intervention Program, the top post-discharge preventive intervention, and one that I'm involved in, the Babies and Pre-Steps model. And in the state of Arizona, we're looking at babies who have the NIDCAP intervention in the NICU, and then it flows over into the babies model with early interventionists in the community. The next thread I'd like to mention is the kangaroo mother care model. And we're all familiar with that model. And what we know is that beginning in 1978, it was used for survival of preterm babies. And many randomized controlled studies have now shown us the benefits in the preterm infant population. Sharpak, Anderson, Ludington, Ho, and now we're putting it into policies, and Kirsten Nyquist is helping us with that. So there's a whole body of literature to show that that kind of intervention is significant for babies. The next thread that I'd like to mention is family-centered engagement as early intervention. And this is with some of the early work by Linda Gilkerson and Ida Cardone with the family-administered neonatal activities and some family-based intervention using the assessment of preterm infant behavior, where you help the parent to understand and elicit some of the communication and showing the strengths and organization of the baby. And then we're now moving toward more of the parent givers as the early intervention provider. We know that early on, Jean Anderson helped us to think about the baby and the mother as mutual caregivers. We know that the Humane Neonatal Care Initiative that was started in Estonia has really contributed to our understanding of the benefits of having babies and mothers together. The couplet care, family-centered care here in Sweden has been very influential in changing not only practices all over the world, but also design of units. Family integrated care by Dr. Shu Lee from Canada is really coming on strong in terms of having babies and parents together for their entire hospitalization. Close collaboration with parents, with Bukitas and Latonen, is very nice in terms of changing the culture and moving more toward family integration. And then the family nurture intervention that we're going to hear more about by Martha Welch and the group at Columbia. So the question is, with all of these threads, are we at the tipping point for it really to be taking hold and being the standard of care? The education, research, policy, and systems change supporting early intervention in the NICU, I think, is leading us in a very solid direction. There are national and international conferences. This is one of them. There are a number of these. The EAD Care Training Consortium that you heard about by Petra. A lot more attention in national neonatology meetings towards developmentally supportive early intervention. You heard this morning a little bit about the European Science Foundation effort to really increase the research in the area of developmental care for extremely premature babies. That was spearheaded mostly by Jack Cizan and Bjorn Vestrup, but it was a huge consortium of people who worked on that. We know that there are more national studies being done to identify what's working in terms of these early intervention efforts. And Rosario Monterosso has now published from Italy some of the infant-centered factors that contribute to better outcomes as well as pain management. There are examples of efforts contributing to policy change that we are seeing emerge now. Great Britain's Department of Health toolkit for high-quality neonatal services includes developmental and family-centered care. The Indiana Perinatal Network, the EFCNI, has been very influential in policy change. We're going to hear today about the Dutch health insurance, which is certainly a policy change, and I'm looking forward to hearing more about that. The Center for the Developing Child in the United States is really helping us to understand how to influence policy change towards early intervention and prevention of later difficulties and disorganization. There's standards and recommendations in ultra-early intervention in NICU. There are a lot of professional organization standards now that include you have to be able to practice developmentally supportive ways. Professional practice standards, design standards for NICUs so that families can be with their babies. There's a new Graven's Consensus Panel on Developmental Care and the AFCNI Standards for Care of the Newborn Health in 2015. So what have we learned about this ultra-early intervention science over the years? We now have a strong base of evidence to guide our future research and application to practice. We can now say research supports the implementation of quality, individualized, family integrative care. And we're moving toward a more comprehensive and thoughtful approach to research. We have a worldwide expanding interest in learning about the art and science of developmental care and early intervention. There's an inclusion of developmental science in undergraduate and graduate programs, and there's quality educational materials for parents that still need to be developed. What changes in clinical practice still need to be addressed? We still need to address continuity from prenatal to NICUs to early intervention to childhood. Clinical care for the mothers as well as the baby. This is of critical importance, both physical and psychological. And I think we have some work to do in that area. Expansion to other areas where infants and parents are hospitalized. And not only NICUs, but cardiac units, surgical units, and more education and certification of individuals and NICUs in basic and optimal care practices. So I've tried to understand for myself these threads of early intervention that have come from our very earliest understanding of preterm infants all the way up to where we're going in the future. And as we look at how they are intertwined, they emerge, they seem to go away for a little bit and then may reemerge in another form, but they're taking on a very powerful effect. And hopefully we're weaving supportive quilts and afghans for our babies. Thank you very much. It's been a pleasure.